So how it goes, and just to give you sort of a little bit of my background, uh, I took care of my first patient with ITP, and it was a child in 1987. And I've been studying and researching ITP for 38 years. Thanks to a couple of mentors that I had that kind of turned me on to how interesting a blood disorder ITP is. So I've devoted a lot of my career to it. So you'll see, like, I'll let you know, like when I quote a study, some of those studies were done here. But I will say that most of the time when new medicines are studied, they're studied first in adults, right? Because before we give a medicine to a child, we want to make sure that it's safe. And we don't want to kind of experiment on a child without knowing it's already safe in older people. So that will be, especially when I talk about the specifically two new medicines, one that just got approved 2 weeks ago, and one that's probably going to be approved soon. So, okay, so here we go. So just so you remember, ITP is an autoimmune problem. So that means your body's making immunity against itself. And the part of self in this case is your platelets, right? So by the definition, and Jessica, you mentioned your daughter's platelet count, that it being in the low hundreds, just below normal. By the formal definition, we don't call it ITP unless it's below 100,000. But you and I know, like in the real world, we know our platelet counts fluctuate every day. Sometimes they dip below 100, sometimes they're 150, 180. So if you're wondering, well, why is it 100 when normal is 150 and above? That's why. We have what we call primary ITP when it's the only problem you have is with your platelets. But some people have what looks like ITP and have other autoimmune problems or infection problems that we know about that are obvious. Right? Like, have you ever heard of lupus? So lupus is an autoimmune disorder that not uncommonly will lead to low platelets. And the low platelets act like ITP low platelets, like the same medicines work and all that kind of stuff. Okay, so here's, let me tell you, and this is only to let you know that it's kind of a complicated, more complicated process than we used to think. In the old days, we just thought that your body like somehow got exposed to a germ and your body made immunity against that germ, and the immunity got kind of confused and attacked your own platelets instead of just the germ. Okay, that's what we used to think. But now we know that when we think about, well, how does your body make an antibody? How does your body make that immunity? It starts, Rosie, is my pointer work at all? Oh, yeah, it does. Look at that. Okay, so it starts up here with this cell, and this is a white blood cell that floats around in your blood, hangs out in this organ here, the spleen, you know, that's under your ribs on the left side of your chest. And that cell is like the antibody production cell, the B cell. It makes those antibodies, and that's that little Y-shaped thing. Those are the antibodies. We know that in ITP, those antibodies glom onto your platelets, right? And when that happens, the platelets change in shape and form, and they get recognized by these cells that are also in your spleen called macrophages. And the macrophages recognize something's wrong with those platelets, and it gobbles them up. And it takes them out of the bloodstream, right? Because your spleen, remember, that's a filter organ, right? Blood flows into it, comes out of it, and like the old blood cells and whatever else is in there that shouldn't be in there gets filtered out by the spleen. And it's because of these cells, those macrophages. Well, here it's gobbling up something you need, right? You need platelets. But in this case, the platelets are kind of coated with these antibodies that your B cells are making. Well, what tells your B cells make antibodies, right? It has to get a message. or a direction somehow. And that direction comes mostly from these other white blood cells called T cells. So all of these cells, T cells and B cells, float around in your blood. T cells are going around giving messages to B cells to say, make antibodies against this or that. And most of the time it's germs, but occasionally it's your own body. And we call that autoimmunity. Now, how does your body respond to that? Your body has to make platelets, right? And this is a bone, right? And inside the bone is bone marrow. And one of the cells inside the bone marrow is this cell called a megakaryocyte. And that's the cell that makes the platelets, right? So now we know that these antibodies aren't just attaching to platelets, but they're also kind of messing with the megakaryocyte and making them less healthy. And then they end up producing less platelets. That's why that medicine end plate works, right? Because the end plate makes your body make more of those megakaryocytes. Every day your body makes a certain number of megakaryocytes. It doesn't really have the ability to ramp it up when you need more. So the spleen, remember, is where these blood cells hang out. So a lot of the production of those antibodies that are going to attack the platelets are made in the spleen, right? So if you took the spleen out, you take away the place where the autoantibodies are being made.
Okay.
So that potentially would help, right? And secondly, it's the place where those macrophages hang out, where the platelets are getting gobbled up. So if you took the spleen out, you'd be taking away the place where the platelets are getting taken out of the bloodstream or gobbled up, right? So it was thought a long time ago, I'll show you a slide on when that came into being, that if you took the spleen out, you help two ways: less autoantibody production, less platelet destruction. And the result would be your platelet count. But there's a downside to it, obviously, which is why we don't do it much anymore. Okay, this is just to show you, and this is based on Dr. Grant Fortuna's medical practice, that of all the ITP he sees, 80% of it is that primary ITP where it's just the platelets, nothing else wrong with it. But 20% is any one of these. Lupus is the SLE, and all these other immune system problems. There's something called Evans syndrome where the red blood is also low. This infection, H. pylori, Helicobacter pylori, that's been associated with some cases of ITP, and that's a stomach bacteria that many of us have. Some of us get an infection with it, and in some, the platelets can go low because of it. So, okay, so the phases, it makes sense to say newly diagnosed is right when the diagnosis is made, but we use that term for up to 3 months after the diagnosis. And then we call it persistent if it's still around. And that's 3 to 12 months from the diagnosis. And if it lasts more than 12 months, we call it chronic ITP. And then sometimes we use the term, and sometimes doctors don't know exactly what that means precisely, but severe ITP, according to this group that made these definitions, Dr. Rodigero, good friend of mine from Italy, presence of bleeding symptoms when a person is first diagnosed that requires treatment, or the occurrence of new bleeding symptoms requiring treatment. So we usually reserve that severe ITP term for people that have a lot of bleeding symptoms. Now, a person can be chronic and severe if it's been more than 12 months and they have a lot of bleeding symptoms. So, okay, so this graph came from a study that I was part of years ago, but it's just an illustration that the lower the platelet count goes, and this on the bottom is the number of platelets, the lower it goes, the more bleeding occurs. So this line here represents the severity of bleeding, and like 1 is not so severe at all, and 5 is very severe. Like, in fact, by this scale, 5 means you died from it.
Oh.
Yeah. So you can see that nobody dies from their ITP if their platelet count is above 50,000, right? Or even above 25,000. But once you start to go really like close to 0, then the risk of that, goes up. And usually if someone passes away from ITP, it's usually because they like have some trauma to their head or something. at the same time their platelet count's super low. So it's just a caution statement. You know, when it's really low, you got to be careful. Okay. All right, I'm going to talk about treatment now. I love showing this slide because I wish we had a cream just to rub on and make everything go away, but we don't, unfortunately. Here's the slide I was referring to before. This is the timeline of treatment over the ages for ITP. I'm fascinated. Just for a moment, I wish I was alive in 1786, because there was this very smart guy. Is a German physician named Orloff, and he noticed that some people that had low platelets would die, and some people, they would just get better on their own. So the people that would die had sepsis or really bad infections. And back then in the 1700s, there was no antibiotics back then, right? So a lot of people died from sepsis. But the ones that didn't die, he said, okay, these people are different. There's something else going on that's not sepsis. And he called it morbus maculosum hemorrhagicus. And at the time, the treatment was leeches. They would put leeches on you. And guess what? The people got better. But later, it was realized, he realized it, that they would have gotten better anyways, whether they put the leeches on or not. Okay, look at that. The first splenectomy for ITP happened in 1916, and it was a medical student who actually thought of the idea of, if the platelets are low because something is wrong with the filter of the blood, maybe if we take the filter out, it'll help. And it actually did in many cases. Well, we first realized that ITP was an immune problem in the 50s and 60s. And then the first treatments, I don't know if your kids had IVIG in their treatment, that first came around in the 80s. And actually, this is an example of the reverse of what I told you before. Usually things get discovered in adults and then trickles down to kids, but that was discovered in kids first. Because those kids, some of the kids that had immune disorders where they don't make antibodies were given this IVIG stuff. And some of them who had low platelets, their platelets got better. Let's see, there's a medicine called rituximab. I don't know if any of your kids have gotten rituximab. That came around in the 2000s, like early 2000s. And then Nplate, which is romiplastim, that's the other name for it. And a similar medicine called L-Trombopag, also called Promacta, was approved in 2008 and 2009. But now we have some newer medicine. This one called avatrombopag or Doptelet, that was just approved in children a couple of months ago. We helped do some studies in it in adults, and we were part of the pediatric trial that was done last year. So now it just got approved. But that's a medicine that works kind of like Nplate, but it's a pill. Now, I'm going to tell you details about this last one, ralzabrutinib, or now it's called Wayrils. It's hard to pronounce. That was just approved last week. Okay, so just very quickly, the initial treatments, you've heard of all of them, probably prednisone or steroids. We don't like to use steroids in our practice here, especially in growing kids, because it can have side effects that can be lasting, and we just want to avoid it altogether. Dexamethasone is kind of a cousin to prednisone, very much more potent. Some people think it works better than prednisone, but there's lots of side effects associated with it. You've heard about IVIG, and there's that kind of this special IVIG. I gotta be honest, we don't really use it much. I was very interested, did a lot of research on it in the 90s and early 2000s, published several papers, including this one, which was the first prospective study in kids. But people started to have side effects from it, and that we didn't realize when we did the trials, and it's pretty much fallen out of favor now. So very few people use it anymore. Now, once those medicines have been used and tried, and we figure the ITP is still there and treatment is still needed, we go to what's called second-line treatment. And these are the medicines for second-line treatment that I talked about on that timetable slide. There's this one here at the bottom called fostamatinib or Tavalis. It's only approved in adults. We don't use it much because the side effects of it are pretty significant. We were part of their big clinical trial to get it approved in adults. And the first patient we put on the study had to come off the study because the side effects were too much. So, and it didn't really work that well. Like when you look at a good response, only 17% of people had a good response. So we don't use it that much. Okay. I don't want to bore you too much with this, but some of these treatments are in the rectangles here, and how they actually work are what the arrows are pointing to. So remember, like splenectomy will take out where most of those B cells are making antibodies in the spleen, so that's removed and things usually get better. That drug called Rituxan, hopefully you'll never have to get that, but that also attacks the B cells that are making the bad antibodies. Steroids kind of do the same thing. IVIG more works on preventing the gobbling up of your platelets, and same with that fostamatinib medicine. The TPO medicines, meaning thrombopoietin, RA means receptor agonist. So these drugs work like the natural hormone that helps you grow your platelets. Okay. You guys might have your own opinion about, are we doing a good job with treating ITP? Like, or are we falling short? So I show you this because this was a big survey that was done with 1,500 people with ITP and 480 doctors that treat ITP. And a few things were sort of realized from this big survey, and mostly from the people that have ITP. Only a quarter of them that filled out the survey, remember this is 1,500 people, only a quarter of them said that they felt like their ITP is well managed. 80% of patients have had treatment failure with steroids or become dependent on steroids. Now, you're a part of our practice, and we don't use steroids hardly at all because A, they don't work so well, and B, they cause more side effects than they do good things. So now this is mostly adults we're talking about. Only 40 to 60% of patients have a durable response to the TPO or A therapy, and that's including Nplate. Now, sometimes as we get older, those secondary reasons for ITP become more prominent than in children with ITP. So when you look at kids with chronic ITP, they much less often have some secondary reason. And a lot of times why the TPO medicines don't work in the adults is because they have other reasons for their low platelets. Side effects, people realize side effects, and a lot of that has to do with steroids. And about 10% of people have no response to any treatment. So we have to do better, right? Okay, so people are working on it. And this is a list. Of course, I'm not going to go through everything here. This is a list of medicines that are being studied right now. This one, though, was the one that was just approved 2 weeks ago, the ralsabrutinib, and I'll tell you a little bit more about that. There is one on here, this CM313. I'll only mention it a little bit because we were invited to be part of that clinical study, and so I know a little bit more of the details about that one. So what is this CM313? Let me just tell you that on the cells that make antibodies, this B cell here, in this case it's called a plasma cell, but plasma cells are B cells also. They have these little nubbins on the surface, and those are proteins. And those proteins serve a very important role in what happens with that plasma cell or B cell. How long it lives, what it does, what proteins it makes, whether it makes antibodies or not, are driven by these proteins that are on the surface of it. So this medicine is a target for that protein on the surface. So if you can like interfere with what that B cell does, maybe you can make less antibodies and the platelet count will go up in people with ITP. So there was this study that was just completed, just published at the end of last year, a phase 1/2 study where people with ITP, and these were adults, were given this CM313 drug, and you can see this is a graph over time, and the green line is the trend of their platelet counts. So you can see before they ever got the medicine, their platelets were very low, and once they got it, a lot of them had a good response, and even after not getting the drug anymore, continued to have a better platelet count. So that held a lot of promise, and now that drug is in what's called a phase 3 trial, that during that time, if the same results are seen in the phase 3 trial, the company will apply for a license from the FDA to get that drug approved. Okay, let me tell you about that other drug, the Wayrils. And that has to do with this enzyme we have in our body. It's called BTK. And remember, enzymes, if you remember from science class, enzymes are chemicals in your body that help like make chemical reactions go faster, right? And without the enzymes, the reaction still may happen, but way less and way slower. So BTK is an important enzyme in how those messages I told you about that the B cell gets to either make or not make antibody. BTK is an enzyme that helps translate that message so the B cell will start making antibodies. So if you can interfere with the BTK, maybe you could stop the message from happening and the B cell will make less antibodies and your platelets will go up. That was the hope. Well, BTK is also involved in that process of gobbling up the platelet, right? So if you interfere with the BTK, like block it, then maybe these macrophage cells won't gobble up so many platelets. Okay, so there's two reasons why a blocker of BTK may be helpful in ITP. Okay, so just recently, there was the study completed. It was just published, look, 2025 in this journal called Blood. And this friend of mine from Boston at Harvard, David Cooter, led that study. And he showed that in 133 people who were given this drug, ralsabrutinib, 85 of the 133, or 65% of them, had a rise in their platelet count. And it took about 15 days on the average, and they held that response for a long time. So that was really promising, especially since the people that entered that study had already failed other treatments for their ITP. So now, these people on this study were watched for a long period of time. So they got the drug or a sugar pill, like blinded, like they didn't know which one they were getting. That's called a randomized trial, right? And if they got the sugar pill after a certain amount of time, they got the regular medicine. Time to go back.
Yeah, well, your call to you when I come. Most of the other adults have dropped, so if you want to keep going in here, you can keep going. We'll just drop the panel or go to the panel.
I'm like only 2 or 3 slides from the end. So like another minute or two, and I'll join you in there. We'll join. Okay. Okay, so maybe cut to the chase. The effect not only was happened in a lot of the people, but it was sustained over time. And we participated in this trial too. And one of our guys on that trial has been on the medicine for 3.5 years, and his platelet count has been good the whole time. Yeah. And very, very nicely, very nicely, it didn't have a lot of side effects at all among all the people on the study. So now another thing too, I don't know if your kids have talked about it, but a lot of people with ITP talk about being fatigued and being tired when their platelets are low, especially. Yeah. Okay, so what they noticed in this study is that people's fatigue got better too. And in the people that whose platelet count didn't go up on this study, their fatigue got better anyways. So the medicine may be like covering more than one aspect of the ITP problem, which is partly your platelets being low, but there are other like, collateral effects, like being tired is one of them, or being fatigued. So ralsabrutinib helped with the platelet count in most of the people, but also helped with the fatigue in a lot of the people. Okay, So that's what's new. The pipeline, of drugs being investigated is long right now, but I told you about the two, one that's about to be approved and one that just got approved. So hopefully though, if I knew you guys were gonna be here in advance, I would have put up my slides on how many kids like that get end plate end up coming off end plate. So I'll just tell you off the record that we were the lead of the big international study on end plate in kids. And we saw that if they were able to come off the end plate, then all of the kids that we put on that study, 10 kids, 8 of those don't take medicine anymore. And all of them are adults now. And they were just kids when we started. So some of them have been off the end plate for 10 or more years.